Welcome back to the ACE-CPT exam prep series. This is lesson 15. We're now in chapter 15 of 18, still working inside the domain of program modification and progression. Today's topic is common musculoskeletal injuries and what they mean for how you program. We'll cover the rotator cuff, the low back, the knee, and the ankle, four of the most common trouble spots you'll encounter with real clients. The goal isn't to turn you into a rehab specialist. It's to help you understand these injuries well enough to train safely around them and to know exactly where your role as a trainer stops. Let's look at what you'll be able to do by the end of this lesson. There are 4 objectives. First, you'll be able to list the common tissue injury categories, the vocabulary you need to describe what's actually going wrong in the body. Second, you'll explain the trainer's role in rotator cuff recovery programming and, just as importantly, where that role ends. Third, you'll describe the IT band's connection to knee pain and why it matters for how you program lower body work. And fourth, you'll identify the training implications for carpal tunnel syndrome, ankle sprains, and plantar fasciitis. Keep these in mind as we go. Every one of them comes back to the same underlying theme. Here's the big idea for this entire lesson, and it's worth locking in early. Continue the plan, don't design it. Let's break that down into 3 parts. First, tissue injury categories. You'll see strains, sprains, tendinitis, cartilage damage, fractures, and overuse injuries. These are the building blocks of the vocabulary we'll use throughout the lesson. Second, the trainer's role. When a client comes to you recovering from an injury, your job is to continue what a rehab professional already outlined, safely and progressively. You're not starting from scratch. And third, still outside scope. Rehabilitating an existing injury is not something a personal trainer does. That work belongs to physical therapists and physicians. Your role begins after the rehab professional has cleared the client and handed off a plan. Let's get precise about the categories of tissue injury you'll see on the exam and in the field. Muscle strains, ligament sprains, tendinitis, cartilage damage, fractures, and overuse conditions. Now, here's a classic exam distinction, so let's make sure it sticks. A strain is damage to muscle or tendon. A sprain is damage to ligament. Same sounding words, completely different tissues involved. If you remember nothing else from this slide, remember that one distinction. It shows up constantly on certification exams, and it matters for how you talk to clients about their own injuries, too. Let's talk about the rotator cuff, one of the most commonly injured structures you'll deal with as a trainer. The rotator cuff is made up of 4 muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. Together, they stabilize the shoulder joint and keep the head of the humerus centered in the socket. Here's the key point for your role as a trainer. When you're working with a client recovering from a rotator cuff injury, your job is to obtain guidelines from the physical therapist or surgeon, and then continue that plan safely and progressively. Not independently, not from your own judgment about what the shoulder needs. You're executing and progressing someone else's rehab plan, not writing a new one. Now let's talk about low back pain, which connects directly back to something we covered earlier in this series. Remember lesson 7? An anterior pelvic tilt, or poor engagement of the transverse abdominis, frequently shows up later as low back discomfort. These postural and stability issues don't stay isolated. They travel, and the low back often absorbs the consequences. So what does that mean for programming? Core stability work comes first. Building a solid foundation through the trunk often addresses low back discomfort at its source. But if a client has a diagnosed low back condition, the same rule from earlier applies here too. The trainer continues the physician's plan. You're not diagnosing, and you're not designing rehab from scratch. Let's move to the knee, and specifically its connection to the IT band. IT band tightness is one of the most common and most trainer-addressable contributors to knee pain. When that band along the outside of the thigh gets tight, it can meaningfully change the dynamics of the patellofemoral joint, which is the technical way of saying it changes how the kneecap tracks as the knee bends and straightens. The good news is that stretching and myofascial release can genuinely help here. But it's not just about the IT band in isolation. Programming for knee health focuses on building strength throughout the hip, the knee, and the ankle together, because the knee is a joint caught in the middle, and its health depends heavily on what's happening above and below it. Let's round out the picture with 3 more common injuries you'll encounter, and how each one shapes your programming decisions. First, carpal tunnel syndrome. This is compression of the median nerve as it passes through the wrist. For programming, the takeaway is simple. Avoid aggravating repetitive wrist positions that would keep irritating that nerve. Second, ankle sprains. Once a client is cleared, balance and proprioception work is typically emphasized. Retraining the ankle's ability to sense its position and react quickly is what rebuilds confidence and stability after a sprain. Third, plantar fasciitis. This one often responds well to calf and foot flexibility work combined with sensible load management, not overloading the foot before it's ready. And as always, the same boundary applies across all 3. Rehabilitating an existing injury stays outside a personal trainer's scope of practice. Let's test this with a practice question. What should a trainer do when programming for a client recovering from a rotator cuff injury? Here are your options. Design an entirely new protocol independently. Obtain guidelines from the physical therapist or surgeon and continue safely. Avoid shoulder exercises permanently. Or ignore the injury. Take a moment to think it through. The correct answer is obtain guidelines from the physical therapist or surgeon and continue safely. Here's why. The trainer's role is continuing the rehab professional's plan, not designing one independently. You're not the one deciding how the shoulder should be rehabbed. You're the one who takes an established plan and helps the client progress through it responsibly. One more practice question before we wrap up. What is a common trainer-addressable contributor to knee pain? Your options are tightness in the IT band complex, elevated blood pressure, insulin resistance, or reduced VO2 max. Take a moment to think it through. The correct answer is tightness in the IT band complex. Here's why. IT band tightness is a common contributor to knee pain that stretching and myofascial release can help address. The other 3 options are real health markers, but they're not the direct, mechanical, trainer-addressable contributor to knee pain that this question is asking about. Let's pull together everything we covered in Lesson 15. Common tissue injury categories are strains, sprains, tendinitis, cartilage damage, fractures, and overuse. Remember the distinction. Strain means muscle or tendon damage, while sprain means ligament damage. Rotator cuff programming continues the rehab professional's plan. It's never designed independently by the trainer. Low back pain often traces back to postural or core engagement findings, the same ones we discussed back in Lesson 7. IT band tightness is a common contributor to knee pain, and it responds well to stretching and myofascial release. And across every one of these injuries, the same boundary holds true. Rehabilitating an existing injury stays outside a trainer's scope of practice. Hold on to that last point especially. It's the thread running through this entire lesson. That's a wrap on Lesson 15. In Lesson 16, we're moving into emergency procedures. We'll cover facility policies, the cardiac chain of survival, and the basics of CPR and AED response. Critical knowledge every trainer needs to be ready for the moment it's actually needed. See you in the next lesson.